Scanning micromanipulators have allowed me to treat a number of lesions, most simply the laryngeal papillomatosis. Whether I'm using it in a scanning line or a scanning circle, I find that I can treat more precisely and more extensively with less damage to the underlying tissues. In other procedures, I have found the scanning technology to be particularly valuable for division of the cricopharyngeal muscle fibers in a Zenker's diverticulotomy, as well as small scanning lines in the treatment of subglottic airway stenoses. I've used the scanning technology in a spot size wider than the smallest spot size to treat large laryngeal cancer resections, as I believe it may provide a better hemostasis, and particularly in areas where the margins of my resection, I am less concerned about taking an extra millimeter of tissue. For example, in the base of tongue, I have widened the spot size and will often use a 1.2 to 1.6 millimeter spot size with the scanning technology to get greater hemostasis as I'm dissecting through the preepiglottic space in removal of the large laryngeal tumors. And so long as I'm keeping an adequate margin around the tissue, I think that that provides a substantial benefit over using a simple spot, where I was often finding I needed the electrocautery then to address bleeding.
A large portion of my practice is endoscopic laryngeal and tracheal surgery. We have a very narrow field of view, and we're able to put in our microlaryngoscopes so that we expose pretty much the entire field all at once. This allows us to bring in an operating microscope and with relatively little repositioning, have that microscope in one position throughout the majority of the case, allowing us to treat the entire operative field without moving the microscope. In this type of instance, the micromanipulator system is wonderful because we have line of sight, it hooks to the operating microscope, and it stays in place with the operating microscope, so there's very little moving of the operative field once the case has begun. With line of sight lasers and the new micromanipulators, this really has improved our ability to treat these lesions and to work in a more rapid, patient-safe manner.
The scanning micromanipulator, I think, has decreased my recurrence rates on papillomas, or at least increased the disease-free interval for these patients, particularly with laryngeal papillomatosis. The biggest advantage in laryngeal papillomatosis is that you can treat a field of tissue down to a relatively precise depth. This prevents injury to the underlying lamina propria and allows us to remove the papilloma more completely and more thoroughly, because all the tissue was treated within a specific treatment region that you can adjust and define. Prior to this, I had used a defocused laser to try to treat wider areas along the vocal folds, and did notice a higher recurrence rate in our patients because I believe the cone of laser effect and activity varied within the treatment field when I used a defocused laser beam. When using the scanning technology with a circular spot, I could treat all of the disease within a certain region to exactly the same depth and degree of treatment.